Hi, my name is Alessandro Vannucchi, and I'm an associate professor of hematology at the University of Florence. The topic of this short presentation is about the ReTHINK study, that is a phase 3 study of Ruxolitinib in early myelofibrosis patients. We know that myelofibrosis is a progressive disease. Indeed, if you compare patients at diagnosis with those seen after 1 year of diagnosis, the proportion of patients who have anemia, thrombocytopenia, circulating blasts, need of transfusions, constitutional symptoms, and splenomegaly is definitely higher just 1 year after the diagnosis, according with this data from the Mayo Clinic. We also know from the data obtained in the prospective COMFORT trials, and this slide is actually showing results from COMFORT-1, that patients who received placebo in this study experienced an increased symptomatic burden over the course of the study, while, as about splenomegaly, there was a progressive increase in the volume of the spleen in patients who either received placebo in COMFORT-1 or best available therapy in COMFORT-2, as compared to patients who received Ruxolitinib. So we also have recent information about the fact that it is possible to improve our capacity to stratify patients according to the risk based on their molecular profile. In this study that was performed in Florence and validated at the Mayo Clinic, we analyzed more than 500 patients with primary myelofibrosis and analyzed a number of genes that may be mutated in myeloid disorders. We found that patients with myelofibrosis who harbor any one of the following 5 mutated genes that are AZXL1, EZH2, SRSF2, and IDH1 and 2 constitute a group that has been defined as high molecular risk. These patients have indeed a reduced overall survival and increased risk of blastic transformation as compared to patients who are in the low risk category. That means that they have none of those 5 mutated genes. And this high molecular risk status is independent of the IPSS or the DIPSS plus conventional risk scores. And when we analyze the proportion of patients who are considered at lower risk disease, such as those in the low and intermediate 1 IPSS risk category, we found that about 20% of these patients are actually harboring prognostically dismal mutations, as are those included in the high molecular risk category. Therefore, in summary, we now have evidence from retrospective series, but especially from the COMFORT studies that are controlled prospective studies, that myelofibrosis is a disease that, if left untreated, may steadily progress to a more symptomatic and prognostically adverse condition. Of course, the fact that until now we had no drug that had been proven effective in halting the progression of the disease has resulted in a watch and wait attitude for patients with early disease. However, now we also have information that allow us to better understand the characteristics of the disease in each patient, and especially to identify those who might expect a shorter survival and be at a measured risk of progression based on their molecular characteristics. Therefore, this data would suggest that approach to early phase myelofibrosis may actually result in a slowing progression of the disease itself. Clearly, this remains a data-driven hypothesis that, however, needs to be confirmed in a study, in a control study. And this is the ReTHINK study. The ReTHINK study is the first mutation-based, mutation-stratified phase 3 trial in patients with myelofibrosis. ReTHINK is a phase 3 randomized double-blind placebo-controlled study that aims at evaluating the efficacy and safety of Ruxolitinib in patients with early myelofibrosis and at high-risk mutational status. Patients with myelofibrosis who are allowed to enter the ReTHINK study are patients with small spleen, less than 5 centimeters from the left costal margin, very poor symptomatic burden, and however they are at high risk of progression and dying because of their mutational status. These patients, high molecular risk, are therefore randomized to receive ruxolitinib at 10 mg twice a day or placebo, and then are treated until the progression-free survival point 1, that is considered according to the progression in terms of spleen volume or symptom. Then patients are treated with ruxolitinib according to the approved dose until the next event of progression-free survival. This is clearly an important study because it is the first study that is based on molecular stratification of the patients, but especially because it might allow us to understand whether early treatment of myelofibrosis rather than a watch and wait approach might be really good for these patients. Thank you for listening to this presentation.